in Athens, and with the nice scar, which is, after a few months, disappeared. At least, when we have very inferior lump, we can use the correction technique, which is a flap from the abdomen skin, and from which we use the adipose tissue, and we make a flap with a replication of the fascia, and we reconstruct the lower pole of the breast with this. That is for the breast. Let's see now for the axilla. For the axilla, classically, of course, the classical indication to have node status is negative axilla M0, clinical positive mold nodes with PM0, in this case no irradiation, but when we have PM positive, we have irradiation. In this case, there is a controversy. In France, in Germany, and in many European countries, we perform radiotherapy after one node positive. In contrast, the Anglo-Saxon in London or in the United States, they don't accept one node to perform radiotherapy, they need to have more than 3. So there is, maybe Professor Castiglione will explain why we have this controversy. I never understand why. Is axillary section still a must? May axillary surgery become more conservative? Yes, after the concept of the sentinel node. Initially, the teaching was that the invasive carcinoma without in situ is a good indication, and we had contraindication when DCIS is extensive or is multicentric. Also in lobular carcinoma because of multicentricity. In fact, also these contraindications are relative because the constant treatment must be proposed for invasive lobular carcinoma, and you know that if you have a mammography course and an MRI, you can assess very well the lesion, the lobular carcinoma, and in this case you could, of course, avoid the contraindication. Also, the conservative treatment can be proposed for DCIS when it is locally in a segment, it's not a diffuse multicentric DCIS, and now because we perform radiotherapy with boost, of course, we decrease also the risk of local recurrence. The characteristic for local treatment, all age are suitable, cosmetic is of course very important, and the special care will be taken for young patients, psychology, and patients who need to feed their breast. The reconstruction is sometimes necessary, but in fact, radical surgery will lose more and more. Now, if we see the last recommendation, which were in St. Gallen, and Professor Castiglione was there, so she can confirm that was the result of the best expert in the world about breast conservative treatment, you see that we have that the absolute contraindication for breast conservative surgery, the age is not more a contraindication. Because you can listen to some surgeon tell you, this patient, she's very young, I will perform mastectomy because she's young. No, it's not true. Also, it is a relative contraindication. Say that surgeon will say, okay, it's not obligatory, but maybe you should have a mastectomy because you are only 30 years old. No more, no more. About the family history, it is a relative contraindication. Yes, in 4%. But if you have a gene positive, of course, it's very high. Also, the margin are very important. And also, contraindication for breast irradiation with follow breast cancer conservation, we have yes in 95%. That is important. So there is no more absolute contraindication to conserve surgery. The remaining relative contraindication, and probably this could be the message, one of the messages of Manosmed, is that the only relative contraindication is the multicentric disease, the BRCA positive, the margin positive, and of course, if you cannot do radiotherapy because you are in the desert or because, I don't know, the patient cannot come every day for 5 weeks to make radiotherapy, that probably are the only relative contraindication. When we see here The important cervical margin, I told you that is the new way which I accept in St. Gallen. Absence of hint means 0 millimeter from the cancer, yes, in 73%. Of course, you should not leave cancer inside. But if it's clean, you can be very, very close. 1 millimeter, you are okay. The surgical margin of tumor is because it's simply the absence of ink. And another important result from this important St. Gallen consensus is that blood vessel surgery might be extended to skin and areola. Is skin mastectomy acceptable? Yes. It's not necessary to remove so much skin as before, only if the skin is involved. And about the margin, is margin toward people is tumor-free? Yes, in 35%. So more and more conservative. Last chapter, Professor, 5 minutes? Yes? 3 minutes, okay. The lymph node surgery. Lymph node surgery, the status, the rationale is actually local regional control. It's not true more this. Better disease-free survival is not true more. The most relevant stage in erosion is not true more. We see yesterday that we have markers and we have gene profile, we have biological identity of the cancer. So this is an old concept. Of course, this remains, but it's not only. And very quick, the classification of breast cancer with the node, you know that we don't have now the N0 and N positive, but we have N